Assalamu alaikum. In this presentation, we shall go through more than 100 multiple choice questions on oral ulcers for ENT and dental trainees and students. These questions are designed to test your understanding of the therapeutic principles and the specific drug choices and the important safety considerations outlined in my previous presentations on the diagnostic algorithm and the treatment options for oral ulcers. These MCQ questions are ideal for reinforcing the key learning points for the ENT and dental trainees. We shall start with this question here. I'll go through the question heading and the answers, the four options. I'll give you a few seconds to choose, and I will warn you before turning to the next slide with the correct answer. And first question, the most common site for acute traumatic oral ulcers: the tongue, the buccal mucosa, the lower lip, or the soft palate. I'll turn now. The answer is B. The most common site for traumatic ulcer is the buccal mucosa, with just less than half of the traumatic ulcers, about 42% of all the traumatic ulcers, followed by the tongue and the lower lip. Necrotizing cyalometaplasia is commonly mistaken for Aphthous ulcers, squamous cell carcinoma, herpetic ulcers, or tuberculous ulcer. We'll stop here. The answer is squamous cell carcinoma, the crater-like indurated ulcer with rolled borders for the necrotizing cyalometaplasia mimics very much malignancy, but in fact it is self-healing. The typical healing time for necrotizing cyalometaplasia ulcer is 7 to 10 days, 5 to 7 weeks, 2 to 3 months, or more than 6 months. Stop here. The answer is 5 to 7 weeks. In fact, the healing starts after 10 days and is complete by usually 6 weeks or so without much scarring. Primary herpetic gingivostomatitis usually affects children aged less than 6 months, 6 months to 5 years, 6 to 12 years, or adults only. Answer is 6 months to 5 years. The peak incidence is between 2 and 3 years of age. It's rare below 6 months due to the maternal antibodies. Herpes zoster oral ulcers are characterized by bilateral distribution, unilateral pattern, symmetrical clusters, or central necrosis. Stop here. Answer is unilateral pattern. The herpes zoster virus reactivation produces unilateral grouped ulcers along a nerve branch, trigeminal branch, for example. Herpangina ulcers typically occurs in the anterior part of the oral cavity, a posterior pharyngeal wall, the lateral tongue, or the gingiva. And stop. Answer is posterior pharyngeal wall. This ulcer is caused by the Coxsackie virus, produces posterior pharyngeal vesicles and ulcers. Hand, foot, and mouth disease is caused mainly by herpes simplex virus 1, Coxsackie A virus, adenovirus, or rhinovirus. I'll stop now. Coxsackie A virus. In fact, Coxsackie A virus and enterovirus 7A causes the oral vesicular eruption in children under the age of 10 years. Necrotizing ulcerative gingivitis is most frequent in the elderly, the young adults, the infants, or children under the age of 10 years? I'll stop here. Answer is young adults. The necrotizing ulcerative gingivitis affects mainly the young adults, the age group of 18 to 20 years, and is associated with things like stress and poor oral hygiene and smoking. Erythema multiforme is most often triggered by trauma or medications or herpes simplex virus infection or an autoimmune disease or poor oral hygiene. I'll stop now. Erythema multiforme is often triggered by medications or herpes simplex virus infection. This is a mucocutaneous hypersensitivity reaction linked to drugs like non-steroidal anti-inflammatory drugs and sulfa compounds and penicillin, or the herpes simplex virus infection. A patient with multiple chronic oral ulcers, which findings suggest autoimmune vesiculobullous disease rather than Aphthous ulcers. Shallow ulcers without vesicles, presence of intact vesicles and desquamative gingivitis, absence of mucosal erythema, or history of mechanical trauma. I'll stop here. The answer is presence of intact vesicles and desquamative gingivitis. These features point towards an autoimmune blistering conditions like pemphigoid or pemphigus. Which of the following statements about topical corticosteroids use in oral ulcers is correct? Corticosteroids can be used indefinitely. It should be applied after meals to dry mucosa. It's ineffective for Aphthous ulcers and it prevents malignancy. I'll stop here. Topical corticosteroids should be applied after meals to dry mucosa. This is where it can be effective. When treating recurrent aphthous stomatitis with topical steroids, patients should be advised to avoid rinsing the mouth after meals, or rinse with antifungal mouthwash if white patches appear, or continue steroid despite candidiasis, or avoid food for 2 hours. The answer is B, rinse with antifungal mouthwash if white patches appear, because topical corticosteroids will predispose to candidiasis, and antifungal rinse is a good prophylaxis or therapeutic measure. Which feature of oral ulcer mandates urgent biopsy? Painful ulcer of less than a week old, or recurrent ulcer, or persistent ulcer for 2 weeks, or an ulcer with a white plaque? Answer is C, persistent ulcer for more than 2 weeks despite trauma elimination would need a biopsy to exclude malignancy. Which therapeutic measure can reduce the recurrence frequency in recurrent herpetic herpes simplex virus infection? Continuous daily valacyclovir prophylaxis, or topical steroids, or topical antibiotics, or regular mouthwash? Stop here. Continuous daily valacyclovir prophylaxis, the daily suppressive antiviral dose would prevent the recurrences and frequent herpes simplex viruses infection. Which oral ulcer condition may indicate a systemic disease if it is unusually severe or resistant to treatment? Recurrent Aphthous stomatitis, or traumatic ulcer, or lichen planus, or herpes labialis? I'll stop here. Answer is A, recurrent Aphthous stomatitis. This may signal that there is a systemic problem like HIV or hematinic deficiency, iron deficiency anemia, or systemic autoimmune disease if the ulcers are unusually severe or resistant to flu treatment. What is the first-line treatment for minor Aphthous stomatitis? Systemic corticosteroids or topical corticosteroids paste or intravenous acyclovir or systemic colchicine. I'll stop here. First-line treatment for minor Aphthous stomatitis is topical corticosteroids paste, like triamcinolone acetonide 0.1%. A patient with recurrent herpes labialis, which treatment should be applied early in the prodromal phase? Triamcinolone acetonide paste, penciclovir cream, chlorhexidine mouthwash, or systemic vulgaris. Stop here. The answer is B. In the prodromal phase of herpes infection, penciclovir cream can help in treating the condition if applied early on the very beginning of the prodromal phase. What is the primary treatment for erythema multiforme minor? Aggressive immunosuppression or local wound care, liquid diet and topical analgesia, or immediate hospitalization or prophylactic antibiotics. I'll stop here. Primary treatment for the mild erythema multiforme minor is at the presentation only supportive care in the form of local wound care, liquid diet, and topical analgesia. What is the recommended application instruction for triamcinolone acetonide dental paste, like Kenalog, for example, in Orabase? To apply it to a wet mucosal surface before eating, or apply it between 2 and 4 times daily after meals and at bedtime, or use it once weekly for prophylaxis, or mix it with water and use as a mouthwash. Stop here. The answer is B. Apply 2 to 4 times daily after meals and at bedtime in Aphthous stomatitis infection. You would need to dry up the mucosa first before applying the paste for better adhesion. When is systemic corticosteroid therapy considered for Aphthous stomatitis? As a first-line treatment for new cases, for very frequent or numerous or major Aphthous, or only when topical antivirals have failed, or exclusively for pediatric patients. I'll stop here. You use systemic corticosteroid therapy for Aphthous stomatitis if the ulcers are very frequent or too numerous or in major Aphthous. This would be a major recurrent Aphthous stomatitis condition that may impair nutrition and affect the quality of life. In addition to corticosteroids, which other class of medications is used in the treatment of Behcet's disease? Beta blockers or anti-TNF alpha agents, or calcium channel blockers, or proton pump inhibitors. In addition to corticosteroids in the treatment of Behcet's disease, you may choose to give anti-TNF alpha agent like infliximab. A 45-year-old man presents with a solitary, crater-like ulcer with indurated borders on the posterior hard palate. The history reveals a recent dental procedure. The lesion is painless and began as a tender nodule. What is the most likely diagnosis? A traumatic ulcer, squamous cell carcinoma, necrotizing salometaplasia, or a major Aphthous ulcer? Answer is necrotizing salometaplasia, which is common in middle-aged men, often on the posterior part of the palate, and can be triggered by local trauma like dental procedures, and its appearance mimics that of a carcinoma because of the crater-like ulcer and the indurated borders. But it is benign and self-limiting. Which of the following is the most common viral cause of oral ulcers in children? A Coxsackie virus, a varicella zoster virus, cytomegalovirus, or herpes simplex virus? Herpes simplex virus is the most common viral cause of the oral ulcers, with a peak prevalence in children between 2 and 3 years. A patient presents with recurrent, painful, round ulcers less than 5 millimeters in diameter on the non-keratinized mucosa, oral mucosa, that heals within 10 days without scarring. What is the condition? Herpetiform Aphthous, major Aphthous, the Sutton ulcer, or minor Aphthous ulcer, or Behcet's disease? Answer is minor Aphthous ulcers, which is by far the most common type of Aphthous ulcers. Between 80 and 90% of recurrent Aphthous stomatitis, they are small and heal within 10 days without any scarring. Which feature is most suggestive of a malignant ulcer rather than a benign one? Painful ulcer with an inflammatory halo, multiple ulcers that occur synchronously, a solitary non-healing ulcer, or history of a blister formation before the ulceration. A solitary non-healing ulcer is probably the most suggestive of a malignant ulcer. In addition to these, other features such as induration and rolled thickened edges are also key suspicious features. A child presents with fever, sore throat, and multiple ulcers on the tongue and hard palate, and have a skin rash on the palms. What is the most likely cause? Primary herpetic gingivostomatitis, or herpangina, hand, foot, and mouth disease, or erythema multiforme? Hand, foot, and mouth disease, they often caused by Coxsackie virus, presents with oral blisters and ulcers on the tongue and the palate, and a characteristic rash on the hands and the feet, and sometimes the buttocks. 60-year-old female presents with blood-filled bully on the soft palate that ruptures, causing ulceration. What's the diagnosis? Mucous membrane pemphigoid, angina bullosa hemorrhagica, linear IgA disease, or bullous pemphigoid? Answer is angina bullosa hemorrhagica, which presents with sudden blood-filled blisters on the soft palate, often post-minor trauma, with no underlying immune cause, sometimes initiated by things like steroid inhalers, for example. Which condition is characterized by periodic recurrent episodes of fever, gingivitis, and Aphthous-like ulcers? Cyclic neutropenia, Ritter's syndrome, Magic syndrome, or IgA deficiency? Answer is cyclic neutropenia, which involves regular 21-day cycles of neutropenia during which the patient may suffer from infections with fever, gingivitis, stomatitis, and Aphthous-like ulceration. Which type of recurrent Aphthous stomatitis is characterized by numerous painful, tiny 1 to 2 millimeters ulcer? Minor Aphthous or major Aphthous, or herpetiform Aphthous, or Sutton's ulcer? Answer is herpetiform Aphthous. This is the least common type of recurrent Aphthous stomatitis, characterized by numerous, very small, but extremely painful ulcers. Sublingual ulceration in newly borns associated with prematurely erupted deciduous teeth are known as Bednar's Aphthous, Riga-Fed disease, Complex spots, or Sutton's disease. Answer is Riga-Fed disease, which is ulceration under the tongue associated with prematurely erupted teeth in a newly born. Squamative gingivitis is associated with all of the following except mucous membrane pemphigoid, lichen planus, linear IgA disease, or necrotizing cyalometaplasia. Answer is necrotizing cyalometaplasia. This squamative gingivitis is actually a feature of all the other three, the mucous membrane pemphigoid, the lichen planus, and the linear IgA disease. Major Aphthous, the Sutton's ulcer, typically heal without scarring, or often with scarring, or within 10 days, or without systemic symptoms. With scarring in 60% of the cases, the major Aphthous are deep, more than 1 centimeter, and persist for more than 2 weeks, and very often scar on healing. Herpetiform Aphthous differ from herpetic ulcers in that they are viral in origin, or occur in clusters but are non-viral, or occur on the keratinized mucosa only, or heal with no scarring. Herpetiform Aphthous occur in clusters but are non-viral. They occur as multiple tiny ulcers resembling those of a herpes simplex virus infection. Cyclic neutropenia ulcers occur randomly, or every 21 days, or constantly, or once yearly. Every 21 days, the periodic neutrophil drops and the patient presents with Aphthous-like ulcerations and infections. The most common site for oral squamous cell carcinoma, the floor of the mouth, the lateral tongue border, the hard palate, or the upper lip. The most common site is the lateral tongue border, followed by the floor of the mouth and the lower lip. Eosinophilic ulcers most commonly occur on the buccal mucosa, the tongue, the lower lip, or the soft palate. Answer is the tongue, where about 60% of the eosinophilic ulcers would occur. Primary syphilitic ulcer, the chancre, shows multiple small ulcers, or solitary clean-based ulcer with lymphadenopathy, or punched out multiple ulcers, or deep crater ulcer with necrosis. The primary syphilitic ulcer is solitary and clean-based, and there is usually cervical lymph nodes. The base is clean but indurated ulcer. Oral mucormycosis typically affects the tongue, the palate, the lips, or the gingiva. The palate. The palatal necrotic ulcers results from vascular invasion in diabetics or immunocompromised patients by the mucormycosis. The granulomatosis with polyangiitis, previously termed Wagner's, shows a strawberry gingiva or Wickham's stria, or punched out ulcers or target lesions. A strawberry gingiva is the answer. The pathognomonic feature of the granulomatosis with polyangiitis is erythematous granular lesions on the gingiva. The most common skin disease with oral lesions is Pemphigus vulgaris, lichen planus, Erythema multiforme, or bullous pemphigoid. The answer is lichen planus. This is the most frequent mucocutaneous disorder affecting the oral mucosa. The oral angina bullosa hemorrhagica is associated with Herpes simplex virus infection, or steroid inhalers, or vitamin deficiency, or candida infection. The answer is steroid inhalers misuse. These blood-filled lesions on the soft palate are linked to the mucosal fragility from the chronic steroid inhaler exposure. Which condition is associated with recurrent oral and genital ulcers and ocular inflammation? Cyclic neutropenia, erythema multiforme, Ritter's syndrome, or Behcet's disease? The answer is Behcet's disease. Which virus is most commonly responsible for herpangina? Varicella zoster virus, Coxsackie A virus, Herpes simplex virus 1, or Epstein-Barr virus? Coxsackie A virus is mainly the cause for herpangina affecting children under the age of 10. Which of the following is a premalignant lesion? Eosinophilic ulcer, lichen planus, necrotizing cyalometaplasia, or Aphthous ulcers? Answer is lichen planus, which is a chronic autoimmune disease with a pre-malignant potential. The risk is up to 3.7% malignant potential. Which condition presents with blood-filled bulli and a choking sensation? Angina bullosa hemorrhagica, or Pemphigus vulgaris, herpetiform Aphthous, or Erythema multiforme? Answer is angina bullosa hemorrhagica with blood-filled bulli on the soft palate that rupture after a minor injury or trauma. Which condition may mimic squamous cell carcinoma but is caused by trauma? Necrotizing cyalometaplasia, eosinophilic ulcer, lichen planus, or cytomegalovirus ulcer? Eosinophilic ulcer, slowly growing ulcer with rolled borders and induration and crater-like ulcer. It has an eosinophilic granuloma as well. Which fungal infection causes oral verrucous ulcers and pulmonary involvement? Histoplasmosis, or blastomycosis, or mucormycosis, or candidiasis? Blastomycosis, that causes a verrucous oral ulcer, and x-rays would show shadows in the lung, and this features may mimic squamous cell carcinoma. Which systemic condition is associated with Aphthous-like ulcers and vasculitis? Behcet's disease, cyclic neutropenia, Ritter's syndrome, or sarcoidosis? Behcet's disease is associated with Aphthous-like ulcers and vasculitis and sometimes ocular inflammation. Which drug reaction would cause a central ulceration with peripheral white striae? Erythema multiforme, lichenoid eruption, Pemphigus vulgaris, or lichen planus? Answer is lichenoid eruption. This disease mimics very much lichen planus, but it's milder and resolve after stopping the offending drug. Which condition presents with erythematous macules and bloody lip crusts? Pemphigus vulgaris, Erythema multiforme, herpetiform Aphthous, or lichen planus? The answer is Erythema multiforme. In fact, bloody incrustations on the lips is very much in favor of a diagnosis of erythema multiforme. Which hypersensitivity condition affects the gingiva and the lips with epithelial sloughing? Plasma cell stomatitis, Pemphigus vulgaris, lichen planus, or Ritter's syndrome? The answer is plasma cell stomatitis, which is a contact hypersensitivity reaction that affects the gingiva and the lips after being subjected to the offending agent. Which syndrome would include oral ulcers, urethritis, and arthritis? Behcet's disease, Ritter's syndrome, cyclic neutropenia, or Stevens-Johnson syndrome? It's Ritter's syndrome, which presents with oral ulcers and systemic symptoms including urethritis and arthritis. What is the recommended timing for applying topical corticosteroids for Aphthous ulcers? Before meals, after meals and at bedtime, every hour, or only in the morning? The answer is after meals and at bedtime to maximize the mucosal contact. Which antiviral is used as a single high-dose treatment for recurrent herpes? Acyclovir, valacyclovir, famciclovir, or penciclovir? Answer is famciclovir, which can be given as a single high dose of 1,500 milligrams, 3 tablets, 500 milligrams each, for herpes simplex infection if they recur very often. Which of the following is a caution when using topical corticosteroids in the mouth? The risk of tooth discoloration, the risk of oral candidiasis, the risk of gingival hyperplasia, or the risk of enamel erosion. It's the risk of oral candidiasis, and if this develops, antifungal mouthwashes may be of help. What is the preferred treatment for the eosinophilic ulcer? Antiviral therapy, surgical excision, topical antifungal, or radiation therapy? The standard treatment for eosinophilic ulcer is surgical excision. They don't recur after this, and sometimes it can be helpful to exclude a malignancy, as the eosinophilic ulcer mimics very much the appearance of a squamous cell carcinoma ulcer. Which of the following is not typically used in the treatment of Aphthous ulcers? Chlorhexidine mouthwash, sucralfate suspension, benzocaine gel, or fluoride varnish? Fluoride varnish is not typically used in the treatment of Aphthous ulcers. It's used for dental caries prevention. The other three are part of the standard treatment of Aphthous ulcers. Topical steroid is used in a dental paste for oral ulcer. Clobetasol, triamcinolone, hydrocortisone, or betamethasone? It's triamcinolone dental paste, the Kenalog, in oro-base vehicle. This is the one commonly used. Which antiviral is preferred for suppressing frequent herpes simplex virus recurrences as a prophylaxis? Acyclovir, valacyclovir, famciclovir, or panciclovir? It's valacyclovir in daily suppressive doses to prevent frequent recurrences of herpes simplex virus infections. Which topical antibiotic may be used in Aphthous ulcer beside the topical steroids? Tetracycline topically, amoxicillin, metronidazole, or ciprofloxacin? It's the tetracycline or the doxycycline mouthwashes that may help in the healing of Aphthous ulcers with topical steroids. Which drug is used topically for pain relief in oral ulcers? Benzocaine, chlorhexidine, acyclovir, or avathiopurine? It is benzocaine gel that provides local pain relief in oral ulcers. Which condition may require intravenous antiviral therapy? Herpetiform Aphthous, or herpes simplex virus in the immunocompromised, or Aphthous ulcers, or necrotizing ulcerative gingivitis? IV antiviral therapy may be indicated in herpes simplex virus and the immunocompromised. IV acyclovir is used for these patients. Which of the following is the mainstay of the treatment for Aphthous stomatitis? Antivirals, or topical steroids, or systemic antibiotics, or topical antifungals? Answer is topical corticosteroids. This is the first-line therapy for the Aphthous stomatitis. The topical corticosteroids triamcinolone acetonide 0.1% is best applied orally in which vehicle? In alcohol base, or aura base paste, or aqueous solution, or lipid ointment? The answer is aura base paste. This adheres quite well to the oral mucosa and prolongs the contact time of the steroids, improving the efficacy. A non-healing, painless oral ulcer persisting for more than 2 weeks should always be treated with stronger steroids, or biopsied to exclude carcinoma, or monitored only, or treated also with antivirals. A non-healing painless ulcer persisting for more than 2 weeks should be biopsied to exclude carcinoma. The most common age group for oral carcinoma occurrence is below 20 years, between 20 and 40 years, more than 50 years, or more than 70 years. As the group more than 50 years, 85% of oral carcinomas occur in this group individuals. Which deficiency can predispose to recurrent oral ulceration? Vitamin C deficiency, deficiency of iron, folate, or vitamin B12, vitamin D deficiency, or zinc? As a deficiency of iron, folate, or vitamin B12 that causes hematinic deficiencies and anemia, and this increases the mucosal vulnerability to ulceration. The characteristic feature of a traumatic ulcer is multiple small ulcers, or a solitary ulcer, or a vesiculobullous eruption, or a painless necrotic plaque. The characteristic feature of traumatic ulcer is that it's a solitary ulcer. Major aphthous ulcers are commonly seen in which systemic condition? Diabetes mellitus, or HIV disease, or psoriasis, or hepatitis C? The answer is HIV disease. The major aphthous ulcers are frequent in the immunocompromised states, like, for example, HIV disease. The first line, topical antimicrobial mouthwash for aphthous ulcers is benzidamine, chlorhexidine, nystatin, or lidocaine. It's chlorhexidine, which reduces the secondary infection of the ulcers and promotes healing. Thalidomide is used for refractory recurrent aphthous stomatitis, not responding to the usual treatment, but it is contraindicated in males or women of childbearing potential, or elderly patients, or the immunocompromised patients. Thalidomide is contraindicated in women of childbearing potential because it is teratogenic. The recommended oral acyclovir dosage for primary herpetic gingivitis stomatitis in adults is 200 milligrams once daily, 200 milligrams 5 times daily, 500 milligrams twice daily, or 1000 milligram once daily. The answer is 200 milligrams 5 times daily for 5 days, because frequent dosing maintains the therapeutic serum levels against the herpes simplex virus. Recurrent herpetic stomatitis can be triggered by all except sunlight exposure, stress, hormonal changes, or fungal infection. The exception is fungal infection, because herpes simplex virus recurs with stress, ultraviolet rays from sunlight exposure, or from hormonal changes, but not from fungal infection. Herpes zoster infection should ideally be treated within 12 hours from presentation, 72 hours from presentation, within a week, or within 10 days. So long as the antiviral treatment is initiated within 72 hours from the presentation, it would maintain efficacy and help in preventing post-herpetic neuralgia. Cytomegalovirus-related oral ulcers are most often seen in healthy children, immunocompromised adults, pregnant women, or diabetic patients. Oral ulcers caused by cytomegalovirus infection are most often seen in immunocompromised adults. Which of the following agents is useful for cytomegalovirus ulcer treatment? Ganciclovir, valacyclovir, penicillin, or chlorhexidine? The answer is ganciclovir. In fact, ganciclovir and vulgacyclovir are both active against cytomegalovirus. The other agents, valacyclovir or penicillin and chlorhexidine, are less or no effect on the virus. The histopathologic hallmark of eosinophilic ulcers is acantholysis, stromal eosinophilia, basal cell vacuolization, or extensive necrosis. The answer is stromal eosinophilia, hence the name of the eosinophilic ulcer. It shows dense eosinophilic infiltration of the ulcer bed. The most common site of oral lichen planus lesions is the tongue, the buccal mucosa, the hard palate, or the gingiva. As the buccal mucosa, which is affected in more than 70% of the lichen planus lesions in the oral cavity. The first-line treatment for erosive oral lichen planus is topical high-potency corticosteroids, or systemic antiviral treatment, or topical antibiotics, or antifungal therapy. The first-line treatment for erosive oral lichen planus is topical high-potency corticosteroids like clobetasol or flecainide gel in an oral base. This is the standard therapy. The first-line treatment for mild erythema multiforme minor includes topical anesthetics and hydration, or systemic steroids, or immunosuppressants, or antibiotics. The answer is topical anesthetics and hydration. The mild form of erythema multiforme minor. This is a condition which is self-limiting, and local care is sufficient for the initial mild disease. Which immunosuppressant requires close blood tests monitoring due to the myelosuppression risk? azathioprine, thalidomide, colchicine, or tacrolimus? It's azathioprine, which can cause cytopenia, and a baseline and regular blood tests would be required. The topical barrier agent Orobase contains gelatin and caramellose, or lidocaine only, or chlorhexidine, or petroleum gel. Orobase contains gelatin and caramellose, which forms a protective coating over the ulcer to reduce the pain. The most common oral site for herpes simplex virus lesions, the hard palate and gingiva, or the buccal mucosa, or the floor of the mouth, or the tongue. The most common site affected by herpes simplex virus lesions are the hard palate and the gingiva. The virus often attacks keratinized mucosa over the palate and the gingiva. Post-herpetic neuralgia can be minimized by early antiviral therapy, systemic corticosteroids only, or topical anesthetics, or a delay in the treatment. Post-herpetic neuralgia can be minimized by early initiation of acyclovir or valacyclovir treatment within 72 hours from the presentation. In necrotizing ulcerative gingivitis, inadequate treatment can lead to candidiasis or necrotizing ulcerative periodontitis, or recurrence of the herpes simplex virus infection, or an abscess formation. Inadequate treatment may lead to necrotizing ulcerative periodontitis, which is a very painful and debilitating condition. The first management step for a sustained traumatic ulcer is to identify the traumatic source, or to begin with systemic steroids, or apply antifungal paste, or perform a biopsy. Identifying the traumatic source is the first line in the management. Local trauma removal is essential before any medications or other forms of management. A 50-year-old smoker presents with painless, non-healing oral ulcer of 3 weeks duration. What is the next best step? To prescribe topical corticosteroids paste, or observe for 2 more weeks, or biopsy to exclude malignancy, or to apply chlorhexidine mouthwash. A biopsy to exclude malignancy is the next best step. A non-healing painless ulcer of more than 2 weeks, especially with induration and rolled edges, is highly suggestive of a malignancy, and a biopsy is required. A patient with recurrent Aphthous stomatitis reports tingling sensation before the ulcer onset. When is topical triamcinolone is most effective? During the ulcer healing, during the prodromal phase, after the ulcer crusts, or after systemic steroids? The answer is during the prodromal phase, even before the ulcer itself appears. The early initiation of the local steroid would reduce the ulcer size and the pain and the duration for the healing. An HIV positive patient has a large, persistent, Aphthous-like ulcer. The first-line therapy will include systemic antibiotics, intralesional triamcinolone injections, topical antivirals, or cryotherapy. The answer is intralesional steroid injections. The major Aphthous ulcers in HIV patients often respond better to intralesional corticosteroid injection. A patient with recurrent herpes labialis presents during the prodromal burning stage before ulceration. The most effective management is apply topical chlorhexidine, starts oral acyclovir, begin systemic corticosteroids, or use topical steroid paste. In the prodromal stage before ulceration, the best effective treatment would be to start the oral acyclovir immediately. Early initiation of the systemic antivirals would help with producing results in that it would reduce the viral replication and the lesion duration. A 30 years old with multiple recurrent painful oral ulcers, unresponsive to topical therapy, now has difficulty in eating. What's the next step? Continue with the topical triamcinolone or begin a short course of systemic corticosteroids or start antiviral therapy or use local anesthetic gel only. Severe or extensive or refractory recurrent Aphthous stomatitis, the best management would be a short tapering systemic corticosteroid course. The best next step would be to have systemic corticosteroids. A 25 years old has painful vesicles on the palate and the gingiva following fever and malaise. The appropriate management: immediate antibiotics or supportive care and analgesics or intravenous steroids or chlorhexidine plus systemic acyclovir for all. The most likely diagnosis for these painful vesicles following a prodroma and affecting the keratinized parts of the oral mucosa in the palate and the gingiva is a herpes simplex infection. If it's still in the vesicle stage with no ulcers, the best treatment would be supportive care and analgesics, because it's usually self-limiting, and best treatment would be fluids, analgesics, and topical anesthetics. But antivirals can be added for severe cases, multiple ulcers, or in the immunocompromised cases. In management of oral lichen planus with erosive lesions that are unresponsive to high potency topical steroids, the next step is to increase the frequency of the chlorhexidine mouthwash or to add topical calcineurin inhibitors like tacrolimus locally, or begin antiviral treatment or add systemic antibiotics. The answer is to add topical calcineurin inhibitors. These are often effective for steroid refractory oral lichen planus erosive lesions. A patient with necrotizing ulcerative gingivitis is treated with mechanical debridement and chlorhexidine mouthwash. Which additional therapy ensures healing? Acyclovir, or amoxicillin and metronidazole, or clindamycin, or corticosteroids? As amoxicillin and metronidazole, a combination of these two drugs for 7 days is the standard treatment of care after debriding, after mechanical debridement and chlorhexidine mouthwash. A 45 years old man develops painful vesicles and ulceration along one side of the hard palate. What is the treatment? Topical steroids only, or oral acyclovir within 72 hours, or systemic antibiotics, or these lesions are not infectious. This is most probably a case of herpes zoster infection along one side of the hard palate, and herpes zoster infection responds to early high-dose antivirals like acyclovir within the first 72 hours, and this would help in preventing post-herpetic neuralgia. A 48 years old immunocompromised patient presents with a large solitary ulcer on the hard palate that lasted for several weeks. Histology confirms cytomegalovirus infection. What's the appropriate treatment? Valganciclovir, acyclovir, chlorhexidine mouthwash only, or amphotericin B. Cytomegalovirus infection responds well to antiviral agents such as valganciclovir or ganciclovir. This is the right answer. A middle-aged woman presents with a single, painful, indurated oral ulcer showing eosinophilic infiltration. The mainstay of management is systemic corticosteroids or excision biopsy and removal of the trauma source, or long-term antibiotics or antiviral therapy. This is a case of a single ulcer, painful and indurated, and has eosinophilic infiltration. This is eosinophilic ulcer. The best management would be excision biopsy and removal of the trauma source. In erythema multiforme associated with herpes simplex virus infection, what's the most useful preventive strategy? Daily chlorhexidine mouthwash, continuous low-dose acyclovir, immunosuppressive therapy, or systemic steroids for all the patients. The erythema multiforme that is triggered by herpes simplex virus recurrent infection is best managed by continuous low dose of acyclovir. This prophylactic low dose acyclovir would reduce the herpes simplex virus triggered erythema multiforme recurrences. Stevens-Johnson syndrome, or toxic epidermal necrolysis, TEN syndrome, differ from erythema multiforme minor in a lack of mucosal involvement, or drug-induced etiology and systemic toxicity, or the shorter duration, or the association with viral infection only. The real difference between Stevens-Johnson syndrome and the TEN syndrome is that both are severe drug-induced reactions with mucocutaneous necrosis requiring hospitalization. So the drug-induced etiology and the systemic toxicity is the main difference from minor erythema multiforme. A patient with mild erythema multiforme limited to the oral mucosa is best managed by systemic steroids and hospitalization, or local wound care and topical anesthetics, or immunosuppressants, or prophylactic antibiotics. In erythema multiforme minor, the mild form, local wound care and topical anesthetics are enough. The oral lesions would heal within 10 to 20 days, and they don't require further management with steroids or immunosuppressants or prophylactic. By this, we come to the end of this presentation on 100 multiple choice questions on oral ulcers for ENT and dental trainees and students. Assalamu alaikum.